Hello, I am Dr. Colleen Kraft, and I will be talking about the future of pediatrics and where we as pediatricians really need to be working with kids within the community. So we're going to recognize the role of pediatricians in building child health. We're going to identify how to work with staff and community organizations in screening, prevention, and treatment of common childhood concerns. And finally, we're going to go through and learn ways to diagnose and manage children with developmental concerns with your community partners. Why do we need a different vision for pediatrics? Well, traditional medical models are not meeting family needs. Families want to know information about parenting, about child development, about physical health. So we need a different schedule and partnership and plans for care. Pediatricians are trusted by families. We are the most trusted source of information for mothers of young children, and that they ask us about everything from health issues to parenting to nutrition and diet. And our advice is more fully followed than other sources. But we are also champions of early brain development, and this is a relatively new role for pediatricians. We are champions for early childhood systems collaboration. We support parents and caregivers and connect our families with resources because this is where day to day they can help build strong foundations for lifelong health for their children. So what do families want? They want more of a focus on child development and behavior. They want more information on healthy growth and development. They would like to come to seminars and workshops. They are interested in technology for information and what's out there to help them in the community with them and their young children. Building health is a competency for pediatricians. And the early experiences that a child has are crucial. By age 3, 80% of synaptic connections in the brain are already made. And by the second decade, pruning begins. That is where the strong connections stay in the brain and the less strong connections are pruned away. And the increased experiences define what that wiring is going to be in that infant's brain. So you can see what the human brain is like at birth. At 6 years old, there's lots of connections. And if those connections are strong connections in reading, in language, in social emotional bonding, then what gets pruned by 14 years of age are maybe some of the things that were worrisome or a bad experience or difficult behaviors growing up. But if those strong connections by 6 years of age are fear, are the feeling of being abandoned, of not being fed or cared for, then what gets pruned away are the really important connections of social emotional bonding, of learning, of working with other people. This is just an idea of what happens with the brain structure and function. So babies are born with their cerebellum, their brainstem, their occipital lobe. Somewhere around 4 months of age, the parietal lobe kicks in, and you've seen a baby roll from front to back, be able to start doing some cooing and talking, being able to reach and grab. That's the integration of sensory data and movement. By 12 months of age, the limbic system kicks in. This is emotions and impulsivity. This is actually why a 4-month-old can't have a temper tantrum. Their brain isn't developed for that yet. But at 12 months of age, kids can certainly have temper tantrums. By 2 years of age, the temporal lobe develops, and that processes sound and language. So that child up until 2 years of age who has been read to, has been spoken to, has been cared for, will begin to develop the actual speech and expressive language. And then finally, the frontal lobe begins to develop in the teenage years and doesn't fully develop until mid-20s, which is where many of our parents are right now. The frontal lobe is responsible for abstract thought and reasoning and judgment and planning. And it's really very important that all along the way that there's integration of sensory data and movement, that there's an understanding of how to self-manage emotions and impulsivity, and how you use language instead of other actions when you're happy, sad, angry, to develop that frontal lobe. So as we look at where pediatricians are, we are in the medical home. And this should be our connection between the child and family who are at the center of the medical home. 2, early literacy and early care, parent support and education, maternal mental health, parental mental health, community support, routine screenings and surveillance from stress, and routine screenings for things like growth and development, screening for anemia or lead poisoning, and all those connections to those services that will help these children out. The idea of team-based care is relatively new in pediatrics, but what team-based care means is that you as the pediatrician are not alone. On your team are people who can help you with your families. You might have a nurse who can help with resources for your families. You may partner with a home visiting or early education system who can help to teach those kids some of the social emotional bonding and regulation, and then move on to even academic work. You can have mental health professionals that you connect closely with who can help some of your teenagers as they become anxious, or some of your parents. And there are even programs where people can co-locate in your office with you to help you help your parents how to understand the developmental milestones of those infants in your care, so that parents know how to better respond to crying or tantrums or toilet training or feeding problems, some of the normal things that happen with young children. Bright Futures are the guidelines for health supervision from the American Academy of Pediatrics. And the understanding is that child health is viewed in the broadest context. It's not only growth, but it's also development. It's how that child is functioning within a family. It's how those parents are functioning. And the idea that lifelong health starts with that early relationship between the parents and that infant. Some of the focus is on child and family strengths, because if you focus on the strengths, you can help that family build resilience, and that healthy communities are necessary to support healthy children. So if we look at the building health approach, there's training, foundation in child development, surveillance, and screening. There are resources. How do we connect families with those preventive parenting and health resources? How do we build brains? How do we tell our families that when you are reading to your child or you're playing with your child, you are building their brain in a way we can't as pediatricians? Help those families be resilient and find their strengths. Team-based care with non-traditional team members. And understanding that relationships that are reciprocal and nurturing are the foundation for healthy childhood development. And understand that that relationship between the parent and the child is a vital sign. That parent who is talking or feeding a baby, who's pointing out things and pointing out words to their child, very different than a family where the children are running around and the parent is on their phone texting, or the child is sitting in a car seat and the parent is not engaged. That relationship is something that you as a pediatrician can understand and help those families develop. So having that parent who's not engaged with that child, have them pick up the child and talk to them and see them smile, and then tell them you are doing a great job in building your child's brain. Or that parent who is interacting with their child, congratulate them, catch them doing the right things, and tell them how they're building their child's brain. How to assess that relationship. Some of the things that you can do is give that family a book with a child and see what they do with their little child. Have them connect with resources on care coordination and early childhood, and ensure that the mental health of parents and children are addressed at each visit. Because neurogenesis, the building of brains, and resiliency are stimulated by vigorous physical play, learning new words, exposure to enriched environments, sleep, eating well, positive nutrition, and social support. These are the things that we can teach our parents how to do to help build their children's brains. What are they stopped by? They're stopped by boredom, depression, distress, and poor nutrition. So if we know these are challenges our families have, we can start to connect them to resources to address these, while telling them something very simple like go outside and play with your child. That's going to build their brain and their health. You want to encourage parents of infants to talk or sing to their baby while they hold them. Look at their face. Respond to his gestures. If the baby is making a noise at you, make that same noise back. You're building their brain by doing this. Give them nice, colorful objects to look at. Babies love to look at faces, and books with faces or pictures of faces are interesting to babies. An older infant, copy their sounds and expressions. Begin to play interactive games like peekaboo or patty cake. Get them to wave bye-bye, shake their head no, shake their head yes, and then read books together, and even pointing to those characters and letting the baby hold the book, put the book in their mouth, pat the book. All of those sensory interactions will help to build that baby's brain. Encourage parents of toddlers to be supportive and to set appropriate limits. Be consistent and establish those routines for meals and naps and bedtime. Make time to play daily. Listen to and answer questions. And rhyme and sing and listen to music together. For toddlers, encourage drawing and building and creative play, something very interactive. Simple musical instruments. Acknowledge desirable behavior often. We talk about time in. I like the way you're doing this. I love the way you're dancing here. I like the drawing that you're putting in there. Because if you acknowledge the positives, your child will try to do the positives. Create ways for your child to play with other children and offer simple choices. Which book should we read next? Encourage parents and caregivers of all ages to give lots of warm physical contact and attention. Be aware of their own moods. Read their own gestures and faces and sounds. Share books. Speak in the language at home. And avoid TV and screens under 24 months of age. Instead, that interactive time with your baby and young toddler is going to be so much better for them. The 5 R's of early childhood education. Reading together daily. Rhyming and playing and cuddling, all important. Routines. Children need to know when they get up, when they eat, when they nap, when they play, when they sleep. Routines help children know what to expect from us and what's expected of them. rewards for everyday successes, and that praise is such a powerful reward. When a child does things right, lots of praise is something very helpful to them. And understanding that that relationship, reciprocal and nurturing, is the foundation of healthy child development. We have to talk about removing stigma of developmental and behavioral health concerns. So start to normalize these conversations. Sometimes your baby may have trouble behavior in this way, or they may not be developing right in that way. You want to find ways to make families feel comfortable talking about development and behavior, because many of our families are very worried that if they tell you that their child is not developing right or behaving correctly, that it's their fault and there's nothing you can do about it. Be open and understand that. Assess that family's readiness to share and address the developmental and behavioral concerns. And if you bring it up, it will make them more comfortable in discussing. Community connections are really important too, because you can talk to a family and bring up, here's a great early education system to help your child develop. Or many of my families have problems with getting enough food. Here are some resources. Or many of my mothers have trouble initially breastfeeding. Here's a support group. All of these things, if you bring them up as the pediatrician, many of your families who would never bring up these concerns might actually say something to you about their child. What if your patient has developmental delay? We're going to talk about why it's important as pediatricians to recognize that we have an advantage. What about developmental surveillance and screening? What are these screening tools? How do we evaluate delay? And how do we connect to resources? So the pediatrician advantage. We are trusted with our patients and families. We have a longitudinal view of the child's development. We know what they were like as a baby and a toddler and a preschooler. And if there's a developmental concern, we see it all along. We know our local communities, especially our preschools, our schools, and our therapy centers. So if we identify a problem, we can talk to a family and not just bring up the problem, but also bring up a solution for them. Developmental delay is really common. It presents in 12 to 15% of all children. But the families don't come telling you this. It's usually not the presenting concern. So recognizing developmental delay, I talk about this as being the third leg of pediatrics. If a child came into your office with a third leg, you would look at that child and say, oh, they have a third leg. We have to do something about this. Development is the same way. As we're looking at all of the other aspects of that child, if there's a developmental concern, we can talk about that in the same way. Not in something that is blaming, but be very objective about it and talk about this as being something you see and note, that it's not something a parent's fault with, and that there are things you can do about it. So we're going to talk about developmental screening, medical evaluation when appropriate, and then referral to therapy resources, because many of these children will do very well if they work with a physical therapist or an occupational therapist or a speech and language therapist or behavioral therapy and parent training. This is really a chart that looks at what is normal development. And you can look at this and see what for a 2-month-old or a 10-month-old or a 12-month-old is normal in terms of their gross motor, their physical development, their fine motor or their hand development, their language, and their social behavior. And this becomes kind of a nice thing to look at and evaluate your child if you have some concerns. So let's go through a few of our patients. Our patient is 3 years old. He comes to you presenting with fever to 39 degrees and cough for 3 days. But he's 3 and he's in a stroller because he doesn't walk yet. He has several words and he communicates with his parents, but his speech is very hard to understand. So let's go through developmental surveillance. This is something that should happen at every visit. It is asking about parental concerns. It's maintaining that developmental history and observing the child. It's identifying the risks and protective factors, and then maintaining an accurate finding over time. So you've seen this child, you've seen him for his illness, and you note that his development is delayed. Next step is to ask about this. And you find that he had a difficult delivery. He was born at 36 weeks gestation, and there's no other family members with similar symptoms. That's important because metabolic diagnoses and consanguinity is something that is common in many of our families. They don't want to talk about that, but if there are a lot of people with this concern in a family, there may be some genetics behind it. So get a developmental history. This child was not able to sit independently until he was 18 months old. Most of our children can do this around 7 or 8 months of age. He can roll and move around when he's prone, but he does not pull the stand and he still needs head support. He understands what his parents say, but his speech is difficult to understand. In his medical history, he had seizures shortly after birth, and he was on phenobarbital, but that was discontinued when he was 12 months old. And he has had problems with recurrent pneumonia. So medical workup. For these tests, you would want to get for this child an MRI of the brain and an EEG looking for seizures, and a chest x-ray because of his fever and cough. Consultation with neurology or pulmonary or genetics, if at all appropriate. And then referral to care. This is a child who would greatly benefit from physical therapy to help build his strength, to help spasticity, and for maybe the parents to get some adaptive equipment to use at home to keep working with this child. Many of our children who have problems like this child do well with chest physiotherapy so they can move those secretions around, and that prevents recurrent pneumonia. And because his speech is difficult to understand, but you know that this child does speak, having him see speech therapy may be very, very helpful. Our next patient is 28 months old. You are seeing him because he injured his arm after a fall from a tree. He is very active and often runs away from his parents. His left forearm has midshaft swelling and the patient is not using it, but he's not acting like he's in pain. You notice in developmental surveillance that he does not make eye contact with you. And again, he's not using that left arm, but he doesn't seem to feel pain with it. When his parents talk, he repeats what his parents say, but he doesn't speak independently, and he doesn't answer your questions. So what's the next steps beyond the obvious fracture in his arm? The parents are concerned and they will say, is this normal boy or should they be concerned? This child's birth and medical history, he is a term infant, no complications, healthy child. But family history is significant for a cousin with autism and another cousin with intellectual disability. This child's developmental history, he had no single words by 16 months. He didn't have any spontaneous two-word phrases until 24 months. He still doesn't respond to his name. He has poor coordination of his eye gaze and avoids eye contact. And all of his speech is repetition of words and phrases. When you look at developmental screening Developmental screening is a brief, validated, standardized tool that aids in the identification of those children where you've noted that there's a developmental concern. And for this child, you would want to use the MCHAT, which is the Modified Checklist for Autism in Toddlers. What you would note is that this child does have significant concern for autism. How do you diagnose autism? Well, this is the Diagnostic Statistical Manual for the criteria. So there needs to be persistent deficits in each of 3 areas of social communication and interactions. So social emotional reciprocity. This child does not seem to understand what's going on with his parents or what's happening in the room. Nonverbal communication problems. He certainly has that. He doesn't seem to understand. And developing or maintaining or understanding relationships. So this child has deficits in all 3 of these areas. You also need at least 2 of 4 restricted or repetitive behaviors. One of the things we note with this child is that he's hyposensitive to his broken arm. He doesn't use the arm but isn't acting like he's in pain. That this child has repetitive motor movements. He's very active and running back and forth. So this suggests, after you've done the developmental screening with a modified checklist for autism in toddlers, and you look at the diagnostic criteria for autism, that this child likely has autism. What's the medical workup here? Well, you want to know if this child can hear. Review again his growth parameters. Most children with autism do not need an MRI or EEG, but if there are other signs that there is difficulty with physical development or seizures, these may be indicated. Similarly with genetic testing, this may be a good thing for this child because he does have a family history of other people who are like this. So referral and treatment. You want to identify who those local therapists are in behavior, in speech and language, and in occupational therapy. Sometimes there are autism-specific preschools that are very helpful for children like your patient. And there sometimes are private preschools that serve children with disabilities. One of the very important connections are to family advocates or an advocacy support group. For children who are just being diagnosed with autism, very important for their families to talk with other families of children with autism so they don't feel alone. They understand they didn't cause this, and they understand there are things that can help their child. Autism Speaks is a great resource, and there are resources in all kinds of different languages for things like the behavior therapy, even things like toilet training, which is difficult for these kids. What are the visual supports? How about feeding behavior? Many children with autism are very picky eaters. But Autism Speaks has a website that is in many, many different languages that can help out your parents and be some of that first family support. One other thing that we need to do as pediatricians is leadership at local levels, because we are the advocates and the voice for these children. Again, many of our families do not know what to do for these children, and they feel very isolated, but we as pediatricians can go to our governments and our elected leaders and say, these are the children I take care of. They may have problems with developmental delay, and we really need somebody who can do physical therapy, speech therapy, behavior therapy. This will help all of the children who are in the care of this government. We are the voice because these children don't speak for themselves, and many of our families don't recognize that they can speak for their children too. And thank you very much for everything that you are doing. everything that helps out your children and families, and have a great rest of your session.